Hi everyone. Apologies for the slightly delayed start there. My name's James Smith, and you should see, I think, on screen my colleague Kimberley Popple. We're here today in our capacity as researchers from the London School of Hygiene and Tropical Medicine. We do have a number of translators on the call, so do avail yourself of the opportunity for translation if that's needed. I'm just now going to share my screen, if you give me one moment. And Kimberley, I'm relying on you to let me know if this is not coming through. So we've got about 45 minutes with you today. We'd like to talk you through a piece of work we've been working on in collaboration with ALNAP over the course of the last 3-4 months. This follows a piece of work that was conducted at the start of the pandemic in the springtime of last year. And this piece of work was developed to really explore the sort of health responses that humanitarian health actors had implemented during the course of the pandemic. And I want to give a very quick thanks to Neha Singh, who unfortunately is unable to be here to co-present today, but also Alice Obrecht and the various institutions and colleagues who've collaborated as part of the COVID-19 humanitarian platform working group.
Sorry to interrupt, James. Are you able to pop on presenter mode? It's just we can see the notes on the side.
Yep, give me a moment. I don't think I can actually. But not to worry if I just give me a moment. How's that, Kimberley?
I'm not seeing the screen now, James.
Apologies all of you, just give me a moment. Are you seeing me now, Kimberley?
Yeah, perfect.
Brilliant. Apologies for that, everybody. So what I quickly want to mention is that we have the Miro board at the bottom of the screen here. So if you scroll down, you should be able to see either embedded into the screen or pop out as a separate URL, the Miro board, in which we have a couple of questions that we're going to refer to in a moment. If you're struggling to see the questions, if you zoom out, you should be able to then see the sticky notes on screen there. And we will come to that in just a moment. With that, I'm going to ask my colleagues on the ALNAP side if we can pop up a couple of quick poll questions just to get us started. So the first of those questions, question 3A for the ALNAP team, is a quick one for those of you on the call. It's really to try and gauge if you were involved in service delivery during the course of the last year and a half. And this is across all sectors, not just health. Were any adaptations made to your programs? And it's a yes/no question. Apologies. I'll just give you a moment there to respond. And if I can ask my ALNAP colleagues if we can, I'll just give it another second. I see only a couple of people have responded so far. While people are responding, you should see the poll just on the right-hand side here, just next to the Q&A segment. Okay, if I ask my ALNAP colleagues just to close that poll for us, because we have another one that we'd quickly like to jump to. or changes, were these changes documented either for internal organizational or external sectoral reflection and learning? And you should see there the poll again on the right-hand side. I'll just give it another second or two. Okay, if I could ask my ALNAP colleagues if we could have a look at those poll results, that would be great.
I think, James, you can see the answers if you answered the poll yourself. So for the first question, it was about 80% yes and 20% no. And then for the documentation question, we've got about 55% at the moment saying yes and 45% no. Brilliant.
Thanks, Kimberley. So we'll come back to those numbers in a short while. With that, I'm going to move us on. So as I mentioned earlier, during the course of the presentation here, we do have the Miro board at the bottom of the screen. One of our colleagues at ALNAP is going to post in the chat 4 questions on the back of those initial poll questions that we'd like you to reflect on and respond to on the Miro board. If you have other questions or comments, or if you have something you'd like us to clarify, please do put that in the chat function on the right-hand side. Otherwise, we encourage you to have a look at the Miro board during the course of the presentation here and reflect on some of those questions. So by way of a quick background to the piece of work that we're presenting today, during the first months of the COVID response, we were asked by ALNAP to develop a rapid learning review with the aim of looking at how organizations should respond to COVID-19 in humanitarian settings. And what this initial review found, they drew from the literature that had been published on COVID from January up to I think March or April of 2020, and also learning from previous outbreak responses over the preceding 5 or 6 years. Multiple knowledge gaps were identified during that early phase, unsurprisingly, related to the dynamics of the outbreak, different risk categories for different demographic groups, which sort of services to prioritize over others, and big questions about which interventions were most effective. That initial rapid learning review identified a couple of operational suggestions and a number of priorities and principles that humanitarian organizations were encouraged to adhere to during the course of the response. What then followed, with the benefit of over a year of implementation experience, was an opportunity to then ask the question of what actually happened. And that's where this latest review came into being. So the purpose here was really to document and make sure the experiences of humanitarian organizations, looking really at how they'd responded, as opposed to sort of what should they have been doing. Now, before we talk a little bit more about what we did and what we found, I thought it would be helpful for us to reflect on how the sort of knowledge landscape has changed since the first case of COVID was identified at the tail end of 2019. This is sort of anecdotal experience from my own experience working in the humanitarian health space over the course of the last year and a half, and I do encourage others to share any of their own reflections. But certainly those first few months, there was really a feeling of kind of information saturation. Everybody had an opinion. There was a huge amount of commentary. There was a lot of speculation, both in terms of the wider sort of social, economic and political impact of the virus, but also from an epidemiological point of view, what might happen. So those first few months were really about trying to understand from an epidemiological perspective how the outbreak was going to develop, but also understanding more about the virus, how it transmitted, how virulent it was, and so on and so forth. During those first months, we saw a lot of modeling, a lot of projections, some of which were more accurate than others, a lot of prioritization and outbreak response measures that were developed and framed around those early models. And as many of you will be aware, certainly those in the policy-making space, lots of norm setting. So a huge number of guidelines that were developed during that initial period, everything from how to manage an ICU, how to prioritize some limited ethical guidance and so on. And then what we've obviously seen has been a huge investment globally in various technologies, so diagnostics, treatment, and more recently, the various vaccines. As the outbreak has developed, we have seen some investment in the publication and dissemination of empirical insights, and this is what we'll get to shortly. So what organizations actually did and some of the changes they made. There is a disparity there in terms of the contexts that have been profiled, and unsurprisingly, low and middle income settings, particularly those settings affected by humanitarian crises, have been underrepresented in the literature thus far. And much less so an investment in the questions of impact and the outcomes of interventions. And again, this is something that we'll discuss more shortly. With that, I'm going to hand over to my colleague Kimberley to take us through the report.
Great, thanks, James. So just as a quick reminder, so the aim of our report was to document and share experiences of adaptations or direct response from humanitarian organizations to COVID-19. And to do this, we first conducted a literature review of the published and grey literature. And here we identified around 48 articles, including 37 peer-reviewed papers after screening 548 records, and 11 articles across the grey literature. And then we conducted a thematic analysis of COVID-19 humanitarian platform submissions. So that was 56 field experiences that were documented on the platform. And for those of you who may not know, the platform is an open access web-based platform which promotes the exchange of field-based COVID-19 program adaptations and innovations. And that's the aim is to facilitate learning among organizations and across different contexts. So some of the limitations of the study, the findings are based on reported experiences, and so they're not necessarily a synthesis of best practice. And this is mainly because, as we said, they are experiences shared with us by organizations, and many of those are not linked to measurement of outcomes or impact, except for a few exceptions within the peer-reviewed literature. And the qualitative experiences from the humanitarian platform were collected in April 2020, so obviously quite early on in the pandemic response. However, then of course we have the literature review to go alongside those. So next slide, please, James. So here is a snapshot of some of the key findings that emerged from the data, and those have been grouped into themes, which I'll go through in a little more detail. So IPC measures, all organizations prioritize the implementation of some form of IPC measures, and this included providing personal protective equipment, installing hand washing facilities, delivering COVID-related training to staff, and putting in place effective triage, screening and referral mechanisms, and providing IPC support at the community level, either in camp settings or in crowded public spaces. Reducing physical contact, So in order to reduce the amount of physical contact between healthcare workers and patients, many organisations reduced their service provision during the pandemic, prioritising those services which were life-saving and integrating other services such as GBV response and mental health and psychosocial support into routine health service provision. The number of visits people had to make to health clinics was also reduced to minimise transmission, and that was through increasing household outreach and home-based care, promoting self-care interventions, and increasing medication supplies for patients. The use of telemedicine, so hotlines, videos, mobile technology was widespread and used to deliver a multitude of services, including sexual and gender-based violence, so telecounselling, case management and legal aid, sexual and reproductive health messaging, remote case processing and mobile checkups for HIV care, audio-visual tools for child protection, and phone consultations for non-communicable disease care. In terms of working with community health workers or community health volunteers, the majority of organisations use community health workers or volunteers to conduct surveillance and contact tracing activities for case management of COVID cases at the community level, for the provision of home-based care for COVID and for other health conditions, and to deliver risk communication and community engagement activities, which included providing messaging on COVID symptoms and care and information on changes to routine health services. For channels of communication, many organisations reported communicating through new or alternative channels to reach key populations with health information. And this included social media, apps, websites, WhatsApp, and these channels were utilised both to deliver health promotion messaging on COVID and on non-COVID health issues, but also to facilitate remote working. For M&E and data collection, during the pandemic, safety concerns and local and global travel restrictions made it more difficult to gain access to communities to conduct usual monitoring, evaluation and research practices, such as in-person data collection. However, real-time evaluation and digital and remote modes of data collection, such as phone interviews, surveys, recruitment through social media and local ads, helped to mitigate some of these challenges and fill some of the gaps in data. For a coordinated response, humanitarian actors reported coordination at all levels, from local to national and between governments and NGOs and between NGOs. And this was key to effectively responding to health needs of populations during the pandemic. So the level of coordination and how successful this was did vary from country to country, but some of the activities included negotiating with governments to access certain areas during movement restrictions, delivering joint sensitization campaigns, and humanitarian actors linking with government registered volunteers. So coordination was strongest where local actors had a strong presence and where health clusters meaningfully engaged with partners and stakeholders. And then finally, for community engagement, like with previous epidemics, organizations reported that community engagement and the management of rumors, mistrust and misinformation around COVID was critical in preventing transmission and allowing organizations to continue to implement routine health services. So likewise, the delivery of context-specific and acceptable health information was essential, and COVID-19 messaging was incorporated into routine programming and outreach activities, such as during antenatal, postnatal care visits and nutrition visits. And engagement with communities took the form of key informant interviews, online surveys, and using social media and door-to-door campaigns to deliver up-to-date health information. So as you can see from those findings, they're quite standard practice for disease outbreak response. There were lots of IPC and community engagement activities taking place. And there's nothing there that's sort of too surprising or unexpected in those findings. Lessons learned from previous outbreaks, and especially from Ebola response, were applied to the COVID response. And that's particularly true for the way that communities were engaged with. And perhaps most unique to COVID was the widespread uptake of remote methods of communicating and delivering services as a result of worldwide restrictions on movement. Of examples from the data in a little more detail, and these are some examples which are perhaps not quite as standard practice as the key findings that you see here. So the first example is related to working with community health workers or community health volunteers, and this is on COVID-19 surveillance activities. So in Afghanistan, one international agency reported deploying around 34,000 polio volunteers who began reporting suspected COVID cases to health facilities and to the organization's rapid response team. These volunteers included doctors, nurses, lab technicians, tribal leaders, and community health workers. And the volunteers would report any suspected case, and then the rapid response team would conduct an investigation and send a sample to the labs. And this disease early warning system covered around 650 health facilities. However, what effect does this then have on polio vaccination? So from March to August 2020, child vaccination drives, including polio campaigns, were halted across both Afghanistan and Pakistan to avoid the risk of COVID transmission to children, caregivers, and the vaccinators themselves. And UNICEF estimates that as a result of this, around 50 million children were left without a polio vaccine. And as a result, polio cases were reported in some previously polio-free parts of Afghanistan and Pakistan. So although many polio vaccination campaigns were resumed in August 2020, the staff and resources from those polio programs across multiple countries were diverted to help fight COVID, and in addition, the lab capacity was largely taken over for COVID testing. So that, along with lockdowns, travel restrictions, and self-isolation of staff, meant that it's been reported COVID-19 caused a huge setback for polio eradication as a whole. And I think this example ties very much into the theme of disruption to humanitarian action, or perhaps disruption to existing service provision. So that's the first example. And then a second example we have relates to communicating through new channels to provide health information to populations. So in Libya, one international agency used a variety of new communication channels to disseminate messaging on COVID-19. So this included using social media to reach people at the household level, broadcasting interviews with different experts, and sharing the experiences of community volunteers through interactive Facebook Live events. The agency developed health promotion videos for dissemination through social media, which included inclusive content for people with disabilities. This process helped to engage community members, volunteers, and sort of one-way sharing of information to a more interactive and responsive mechanism. And then another example of communication comes from an international agency working on gender-based violence prevention and response in Lebanon, who developed a national campaign to promote awareness of GBV hotline during lockdown in Beirut. So the aim was to ensure that those facing abuse knew that they could still access services during the lockdown, and the unique conditions of the lockdown were used to shape the design of the campaign. The organization then promoted that campaign across various social media platforms, including Facebook and Instagram, and leveraged social media influencers and local media outlets to assist in promotion activities. And examples of this included encouraging influencers to subtly spell out the hotline number during videos on cooking and other topics which are unrelated to domestic abuse. And I think it will be interesting to see whether these adaptations represent a sort of evolution of programming or a kind of incremental change over time to incorporate new ways of communicating, and whether these will be sustained beyond the pandemic response. And the final example we wanted to share is related to reducing physical contact through implementing self-care interventions for non-communicable diseases. So during the pandemic in northern Jordan, community health volunteers were involved in a program to establish disease stability and medication needs for Syrian refugees with hypertension and/or diabetes. So These volunteers followed up with patients with a monthly phone call to provide information on self-management and psychosocial support, ensure sufficient medication, to assess medication adherence, and to screen for complications requiring referral, and also for COVID-19 symptoms. And a couple of other quick examples of self-care interventions reported included training patients in Lebanon to self-monitor their insulin and sugar levels at home, and community health workers training mothers in Afghanistan to perform MUAC, so the middle upper arm circumference measurement, in their own households, and to make referrals to community health workers where necessary as part of nutrition programming. And I think that the promotion of self-care as a way for people to self-manage their own health could fall under the more sort of revolution in programming category, or a more kind of transformative change, but definitely has the potential to be sustained and amplified across not only non-communicable disease care, but also other health components beyond the pandemic response. So those are just a few examples of the experiences that were shared with us through the research. And I think we will go back to James now just for a few.
Thanks very much, Kimberley. Before I dive on in with a few final reflections, drawing out a couple of observations from this piece of work, I'd just like to direct you back to the Miro board. So if you scroll down screen, you should see it either embedded there, or you can open it up as a separate page. We're really keen for those of you, the 80% who said you did make changes, did make adaptations to programs during COVID, to share what those changes and adaptations were. And if they were documented, where they were documented, and that's an important reflection point for these final observations. If they weren't documented, why not? And what do you feel could be done to make that process of organizational reflection, learning, and practice more efficient? So with that, I'm going to come on to a few final reflections from our side. It goes without saying, and we've certainly heard a lot about this during the opening discussions today, that there's been a huge amount of disruption across the humanitarian sector over the course of the last 22 months due to COVID and a constellation of additional factors. Many of the changes that we've seen in humanitarian health programming, as Kimberley has mentioned, correlate with established pillars of outbreak response. What we've noticed, and again, this has emerged from a number of previous reflections, particularly in the wake of the West African Ebola outbreak, has been that a number of these lessons learnt don't necessarily differ widely from lessons that we have supposedly learnt as a sector during the course of a number of previous outbreaks. During those first few months, and indeed into 2021, we've seen a huge volume of commentary, a lot of speculation, a lot of mathematical modelling, various different normative and descriptive outputs across the humanitarian sector and in wider public and professional discourse. Despite this sort of saturation of information, and despite clearly a significant reflective architecture that exists across the humanitarian sector, there are a number of persistent knowledge gaps that we've identified, and it's really worth emphasizing that we did struggle to identify literature that really felt that fell within the inclusion criteria for this particular research project. There is a somewhat limited public documentation and dissemination of changes made to humanitarian programs, and that's perhaps reflected in the that changes were made, but only 50% are saying that these were documented either internally or externally. Where we do have changes documented, one of the other major challenges is that there are very limited causal associations drawn between what organizations did what they changed, and the impact that this had. Now, it might be a little too soon to raise questions of outcomes and impact, and indeed that will be one of the big questions as the pandemic progresses, and in the wake of the pandemic, the wider direct and secondary impacts of COVID-19. But certainly looking back on over a year's worth of publications, we found it very difficult to draw out information related to the relative effectiveness of changes and adaptations. So with that in mind, rather than drawing out recommendations in terms of activities that humanitarian organizations should adopt, or different approaches that should be adopted, we have some broader reflections here related to the ways in which experience and knowledge are translated for wider sectoral consumption. It seems to us critically important that we continue to invest in and integrate learning across humanitarian programs, specifically with a focus on outcomes, in addition to simply saying this is what we did, this was the number of people that were reached, and so on. Very important that we establish feedback loops, and again, drawing on the ongoing conversation related to locally driven programming during COVID and the wider localization discussion. These feedback loops and these integrative kind of approaches are really critically important to ensure that learning that's happening at the local level is fed into regional and global guidance and recommendations. And particularly methods and approaches to ensure that that guidance can then be adapted and adopted in a contextually specific way. And finally, the importance really of dissemination of experience and learning in a way that is publicly accessible. One of the things that we found was that there are a number of organizations that are heavily invested in learning, real-time learning, and those of us who've worked for operational organizations will have experienced the sheer volume of internal reflection that's ongoing all of the time, but only a very small proportion of that at present feeds out into spaces that allow for wider sectoral or cluster specific debate and learning, and that's a real impediment to these sort of conversations, which are quality evidence, and to then inform ongoing programming. So with that, I'm going to bring us back to the group here. Kimberley, I don't know if we have any observations from the Miro board. I'm just pulling us back on screen here.
Yeah, we've got a couple on there, James.
Let me just have a little look. So I'm just zooming in. So we've got a couple of comments in relation to adaptations made. So one participant working in the health sector, standby of regular activities, development of a COVID-specific response. A colleague from the peace sector, moved conflict mediation activities online. That's interesting. And then discussed COVID and other issues. Okay. I'm just going to talk us through in the last couple of minutes the comments that are being made. So where adaptations were documented, we had some internal documentation by the meal team for ease of sharing between different country teams, but then also an observation that these changes weren't documented aside from in documents to request additional funding. Okay. Where adaptations weren't documented, it was due to a limited number of staff, everyone acting on the immediate response. Okay. While we wait to see if there are any further comments, I'm just going to have a quick look at the chat and the Q&A here. Okay, so we've got a question from Annalise. What new specific to COVID, not to any pandemic adaptations in health response have you seen that have the potential for long-term adaptation? Kimberley, I don't know if you can speak to that. So adaptations implemented during COVID that have the potential for long-term adaptation. Certainly from my experience of working with this review, I just reaffirm the observation you made, Kimberley, about virtual and remote ways of working, which I think has certainly in a number of the evaluations we've seen really come through strongly as something that the sector and a number of institutions would like to hold on to longer term. Kimberley, I don't know if you have any further reflections there.
Yeah, I would agree, James, and I don't know that it's necessarily, you know, that this is the first time that these ways of communicating or delivering services have been seen, but more, as I was saying, they're just so widespread now. So it seems that they're more kind of mainstreamed across only sort of communicating you know, sort of staff amongst themselves or with populations, but also, you know, just really using those channels to deliver both health information, but also to change the way in which services themselves are delivered and the kind of modalities that are being used, like we sort of mentioned, self-care, which again is not new, but if there are specific examples that have come out of COVID, which weren't necessarily being done before, which I think I shared a couple of those, then, you know, those have the potential there as well, I think, for longer term adoption and then adaptation by different organizations.
Thanks, Kimberley. Perhaps just one final reflection on that question, Annalise, is that I think when we're talking about adaptations and changes that are more related to sectoral culture, that will really be dependent somewhat on the political investment in those changes. And I'm thinking again to the opening panel discussion earlier today. But when it comes to sort of programmatic changes that are more technical in orientation, it's perhaps a little too soon to know. And I think, for example, the work around adaptation to NCD's programming, I would expect that a number of humanitarian health actors will be waiting to see what impact those the stretching of follow-up appointments and so on has had on treatment outcomes, patient satisfaction and so on. And at the moment, for the most part, with the exception of very limited evidence for certain adaptations, there just isn't yet that high quality evidence related to the impact that changes have had on patient and community outcomes. I see we're approaching our 45 minutes. I do encourage any final comments or questions. Otherwise, I think our time with you all is up today. Please do feel free to have a look at the first report published in April of last year, and we will of course be working on finalizing the review that we've just discussed today for dissemination to the ALNAP and humanitarian community in the next couple of months. But with that, I would like to say thank you all for your time. Thank you for your engagement, and please do direct any further comments or questions to us over at LSHTM.
Thank you.